Good. So welcome everybody to this Saturday monthly meeting of the Compagnons Hepatobiliaires. I will chair this meeting, of course, with Monsieur Bismuth, who's always honoring us with his presence. Now, we have a few cases to discuss. We have a case from Lugano of a real patient for which I'm puzzled, and I would really like your help. So can I share the screen? You have to allow me to share the screen, Angelica. Yep.
Okay, go ahead.
Right. Right. Do you see this? You should see. Right. The problem is recurrent cholangitis after 2 biliary repairs and a cholecystectomy. The story, he's now 79. The story starts in 2002 when he has what seems straightforward cholecystectomy. From 16 to 20, he has multiple episodes of cholangitis and 14 ERCPs for stones without being presented to us. And I think this is part of the problem in my interpretation of the case. In 16, he has one of these 14 ERCPs and a cholangioscopy who describes fibrotic appearance of the left system. And the thing evolved until eventually in 2020, he's presented to us for what is quite clearly a stenosis at the hilum, atrophy of the left lobe, and a narrow common hepatic duct. So the endoscopist, very late, but now he decides he can't do anything more for this patient, and he refers him to us for a biliary repair. And I show you the original, and it's easier for me to go on my program for showing the X-rays, and then I will. Right. This is one of the first ERCPs. Do you see it? In which he had a stone here, and the bifurcation of the bile duct is fine. The liver is dysmorphic, but we will see that later. And we don't have much more to say on this ERCP. I can show you other with a left bile system that is, as we will see, in an atrophic left liver. But otherwise, the situation here is not particularly complicated. But as I tell you, from this one, he has 14 other more ERCPs before he's brought to our attention. And I show you then the next one. This is the MRI roughly at that time, where he has the stone.
Yeah, but we don't see the MRI. We only see the first ERCP.
Right. Maybe I have to change it. Now do you see it?
I think you're sharing
No.
the screen.
So
No.
I have to go back and sharing the screen. Just a second.
Just one question, Pietro. From the first to the last ERCP, did he have all the time stents?
No, he never had stents. He had
So
just
only dilatations.
Or dilatation, and just a second, interrompi la condivisione. Condividi. Right. Here you see the MRI.
Tu ne l'as pas sur WhatsApp?
Right. So no great thing to see on this one. Can you see this?
Yes.
Yeah.
Mm-hmm.
And here you can see that the left biliary system is dilated, abnormal, whilst on the right, we've seen that this part, which is not well expanded on the MRI, but in fact is no great problem. But this is in fact where he will develop a stricture later on, together with the left biliary system, with stones and a dysmorphic left liver. I can show you. Can you see this?
Yes.
You see,
Yes.
he has virtually no left liver with dilated diseased bile ducts on the left. And so when the patient is finally sent to us, we decide, well, a piece of cake, the stricture at the bifurcation can be dealt nicely with a cholangioplasty, and we will resect the left liver, and we do a nice biliary anastomosis, mucosa to mucosa, on the two ducts of the anterior and posterior sector. The parenchymal sacrifice here would be null, and we take away the diseased liver. Meanwhile, the patient has been investigated for sclerosing cholangitis, IgG4, and all that. All that was negative. So we interpret that this is mistreated bile duct stones with what Professor Bismuth said the other time, that after a while the bile duct stones, if they recur and they're mistreated, they go into the liver, then it becomes autochthonous intrahepatic stones. But this, we felt that it was disease confined to. Yes.
Here we stopped to discuss before the operation about the what was the exact disease of this patient, badly treated by 14 ERCP.
Yeah.
There are, of course, bile duct stone, it is evident, but there is a stricture above. And if we look at the story, that means the symptom appear almost 16 years after the cholecystectomy. What it means? It means that the stricture was partial, and it took time to have the symptom. And the symptom of recurrent cholangitis is usually due to stone inside the intrahepatic bile duct due to the cholestasis, the permanent cholestasis.
Yeah.
The fact that there is a stone below the stricture, which is a little paradoxal, I think is a consequence of the ERCP. They delayed for a short time before the stricture recur, but in the meantime, some stone intrahepatic migrate down. This is the association, which is always strange to have bile duct below a stricture. Indeed, there is a relation between the stricture and the bile duct, for it was formed before the stricture was dilated. And so you arrive to a situation where, of course, you need to do surgical treatment. What you did. I don't know, we don't know what will follow now, but for me, you did well. You did well to do repair, which is a biliary repair. The stricture was not very high, it was at the level of the confluence. This is correct. This is type 2, no? No, type
I took it as a type 3, in fact.
Type 3,
because
yeah.
the roof of the, no, type 2, because we could preserve the roof of the,
Now, don't confuse with the ELA.
yeah, it was type 3. It was a type 3 stricture because we had intact only the roof of the confluent.
The roof was blocked.
Was intact.
Arrived to the
Good
roof.
mucosa, good mucosa on the roof of the confluent and of the left bile duct. But we were, in fact, very well exposed because I resected the left liver because, of course, there is almost no parenchyma on that side, just diseased bile ducts. And I was extremely well exposed. And we put together with a cholangioplasty the anterior and posterior duct. And I said to the patient, we've solved the problem. You will never have fever anymore. And it will be all downhill from now. And 10 days after the operation, he starts making fever again. And basically, he's never stopped. And we did the operation in, just a second, I have to take away the, and yep.
When was your operation?
I tell you now, can you see this?
When was your operation? When it was?
The operation was in 21, February 21.
February 21. And after your
I was very happy with the operation. And I was really, and that part of my problem, the histology, left liver, concentric periductal fibrosis, mild inflammatory changes, no atypia, normal hepatic globules, no neoplastic tissue. And then the via crucis starts because 10 days after, he has the first of what are one episode of cholangitis per month, roughly. So we, with bacteria that are more and more resistant. And to make the long story short, he's never stopped, despite having lost, because I told him, what we did to investigate the problem of recurrent fever, we checked, of course, the repair by cholangiography, and it goes down very well and it follows. We did esophageal gastric transit to check that there was no reverse peristalsis or whatever opacifying the bile ducts, and they do not opacify with an opaque drink into the stomach. So the patient, because I'm no longer able to offer him something, he decides to go to Bern. And in Bern, they do a cholangioscopy through the percutaneous drain that I put, and they found that the anastomosis was normal, permeable, but there was a anastomositis, they say, an inflammation around the anastomosis. And this was the problem. So they try to infuse antibiotics along the drain. They try to dilate maybe a stricture up above. Eventually, they take him back to theater. And in theater, they dismount my anastomosis. They resect the anastomosis. They do a higher anastomosis on 3 ducts on the right liver. And the patient back to square one. Once a month, severe cholangitis with bacteremia, with other germs that are more and more resistant. And eventually he's tired of burn and he comes back to me now, um, uh, saying, what can I do? And he's infectious disease specialist. And I'll make it, at present, he's got a prophylaxis with, he has to go 3 times a week, like a dialysis patient, to have vancomycin and Imvans intravenously. And with this, he holds about a month between episodes of cholangitis that are never with septic shock. They're very well tolerated, but it goes up to 39, 40 temperature. And to the point that we almost thought, this is not cholangitis. So we turned him all around colonoscopy, gastroscopy, medical internist consultation to check for rare diseases that may give, because his liver tests when he has cholangitis are strictly normal. Again, that's another particular point. But indeed, his bacteria have colonized his biliary tree, probably from the beginning. And the Bern liver surgeon, who's a very clever, and he feels that this patient has been treated too long with conservative ERCPs. He has colonized the gel that layers the bile ducts, and this cannot be treated otherwise than with prophylactic antibiotics, and when things happen, treat him. I wonder whether you had a similar patient and whether you can help me with something intelligent. I've been thinking of changing the bacteria of his gut with microbiota manipulation, other things you may have in mind. Thank you very much.
Okay, what is your question just today?
The question is there anything that I can do that is not, or it is more specific, more intelligent than giving him 3 times a week prophylactic antibiotics?
But what is the cause of cholangitis?
There is no mechanical cause of cholangitis. For the Daniel Candinas, who's an experienced hepatobiliary surgeon, he feels that the bile system of this patient is colonized from long-standing with bacteria, and that we will never be able to sterilize this patient. I mean, the ideal treatment would be liver transplant, but he's 80.
Are you sure that the 3 anastomosis, now there are 3 anastomosis?
Yeah.
Are you sure?
It's 1 anastomosis on 3 ducts.
Yeah. Are you sure they are patent?
On MRI, I can show you the MRI. Yes, and in fact, if you see, yes, and what's also quite surprising is that I showed you his liver function tests. They are absolutely normal, and they don't.
Gamma-GT are normal.
Normal. Alk-Phos normal.
Gamma-GT are normal.
Yeah.
Okay. I have another question.
They've always been normal. After my operation, they've always been normal. Even when he has, maybe he raises his gamma GT 10 points during the episode, but that's it. Otherwise, strictly normal, even now. I show you the MRI now. This is the most recent MRI.
Let me ask you a question. As you know, I think there are 2 causes of cholangitis. One, the most frequent, is obstruction. The second one is reflux. What is the length of the jejunal loop?
We did 70 centimeters.
But
and
now,
now I don't know, because Bern has not described how long it is, but they dismounted mine and they remounted another one. I've toyed with the idea of lengthening the loop. Not 70, but making it 1.5 meters.
And Pietro, might there be a stenosis in the transmesocholic passage?
We did that. We did a transit, and it goes down like good. And on this one, it doesn't seem, it's not dilated. And when we did when we put a percutaneous drain and we injected to see the progression down, it progressed down nicely.
I see, yeah.
We have two.
Because there is a dilatation of.
There is a slight dilatation of this one. I agree.
Yes,
But before putting in a drain now and redoing it all, if you think that I have to do that, I will do that. But with normal liver function tests, but maybe I should do it. I'm very happy to do it.
Are you sure the cholangiogram is complete?
Yes.
You have the 3 branches?
Yes.
Can
yes,
I
but
ask?
Also, I don't have. I mean, this is slightly dilated. We could put a drain here and go and probe the whole region again. That's something we could do.
But I think you may do a drain by the jejunal loop. If you puncture jejunal loop, you may enter by endoscopy in the 3 branches. I think it's better.
It won't be a piece. It won't be a piece of cake to do. We could do that, but because it's quite high, and the anastomosis is.
May I ask something?
Everything.
Thank you. Is there you showed, I was late, I'm sorry. Is there any areobilia?
There's been all the time. I haven't done a recent CT to look at it.
Because as Professor Bismuth said, either in that type of problem, either it's the stenosis or a reflux. If there areobilia, it's not a stenosis. And I have experienced some of those very difficult cases of recurrent cholangitis after Whipple procedure. And I have, for example, 2 cases, and including one of an 80 patient like that, exactly like yours, with no stenosis, no evidence of reflux. And I think that it is a dysfunction of the loop, of the intestinal loop. And he has recurrent angiolitis, exactly like yours, not severe one, just fever without any change in the hepatic profile. And we only do some probiotic to lower the frequency of the cholangitis, but I didn't find any solution for that. The only thing we can say that it's not very serious. It's not, we have no hemodynamic shock, no severe sepsis. It's only fever once a week, once a month. And with probiotic, it's 1 each 2 months.
Right. What probiotic do you give?
This is some, it is Ciflox plus, it's only intestinal antiseptic, and it's done in our hospital. It's only it's done by the hospital. We call that G20 gels. Well,
G20 gel.
yes.
Can you send me a bottle?
Yes, I will. But believe me, it's not working very well. So it's only, lowering the frequency of the cholangitis. But if you put a drain, I don't think it will solve the problem. the patient will have a drain. That's all.
On the top. On the top.
I come back.
Pietro,
Sorry, I come back to my phobia. My phobia is before treating cholangitis by some drug, we must be sure there are no obstruction and no reflux. I think that reflux, I doubt we have reflux. For there is, I say, Laurent, there is no air in the bile duct, no time. You do a barium transit, and you pacified you said you pacified only the extremity of the loop, but not the upper part. But I would like to exclude that.
Yeah, I've done that. I've done the back.
To be sure. Now I have a question to you. When you did the operation in 21, you show us a biopsy of the left lobe that you remove. But what is important for the future is the quality of what remain. That means the right lobe. Did you do a biopsy of the right lobe? The
No.
right lobe. You know that the evolution of a structure is to have what is said now secondary biliary cirrhosis.
Mhm.
But gamma GT are normal, you said. So I doubt about this diagnosis.
Yeah. We can do a biopsy of the right liver. Yeah.
Can I say something?
Who's I?
It's
It's
Gina.
859082.
Okay, it's Gina.
Oh, right, Gina. Hello.
Okay, hello. Sorry, I was late. I had a similar question. I'm sorry I was late. Difficulty of connection. When you did the operation, of course, Professor Bismuth said you should do the biopsy of the right liver, which I agree. But did you do a intra-op cholangioscopy?
No, I was happy as I can be for the operation. I took away the diseased liver. I did a nice reconstruction of on two bile ducts. I probed with a Kelly clamp, and it would go up in the two ducts nicely. I would not do a cholangioscopy. I mean, I don't think that anybody sensible would do a cholangioscopy at that time.
Okay, it's because I've reviewed all the series of Paul Brousse of all the patients who develop recurrent cholangitis after having a cholecystectomy and having a recurrent cholangitis and several ERCP. Unfortunately, these patients developed secondary cholangitis and they develop inflammatory of the whole biliary tree to the point that all these patients, when they were having a biliary repair in Paul Brousse at that time, systematically, and Professor Bismuth recalls it very well, we fixed the loop under the abdominal wall because we knew that we had to come back again because they developed secondary cholangitis. All these patients had several episodes of inflammatory inflammatory episode of cholangitis. Each time we put the endoscopy, the external maneuver, we never found any stones, but we used to flush and treat the episodes. But what happened is that we treated this patient with ursodeoxycholic acid, and it improved the symptoms. It improved all of them. It was a series of 300 patients, and I remember very well, these patients developed several episodes of cholangitis with no stricture because each time we did an intracholangioscopy and cholangiography, we never found any recurrent episode of stricture per se, but we used to flush the biliary tree and they responded, medically speaking, but they used to come back. And it's true that with time, they develop a secondary biliary cirrhosis, but not all of them. Yeah. But it's true that the biopsy of the liver of the right lobe is very important for this patient.
No. Gina, it's very interesting. Of
know,
the 300 patients in Paul Bruce,
Yeah.
how many developed recurrent cholangitis? In how many the problem was not settled?
Oh, I can tell you by, but I can verify because I have all the series. But I can tell you that there were, among all of these patients, to the point that we had to transplant them, there were about 5% of them that they ended up, because they were young, to transplantation. But the elderly patient responded to ursodesoxycholic acid. It was the series of the intrahepatic stones, Professor Bismuth, you might remember, and I reviewed all the series of this patient.
This is strange, Gina. It is very strange. I don't remember.
Oh, yes.
Remember at all what you said.
Presented it.
The series, we publish it?
No, we presented to the AFC en 1998 et 99.
Can you find this?
Oh yeah, I have all the paper. I kept all the series, all the data.
That means cholangitis without obstruction.
Without obstruction, they developed even it was the series of the intrahepatic stones with no mechanical stricture, and all of them had the biliary repair. But some of the patients, as Pietro said, unfortunately, before coming to us, had multiple episodes of ERCP and everything. And it was bile stasis and inflammation, secondary inflammation of all the biliary tree and the wall of all the biliary tree. And we called it as a secondary cholangitis, sclerosing cholangitis. Not primary, but secondary.
Yeah, okay, secondary, but secondary, there is fibrosis on the biopsy and gamma GTR increase. It is
not all of them. No. Some of them had normal LFTs. So that's why that it was surprising, but I agree.
I would like to find all this, what you write. It is very, okay, we will discuss about that. And you send what you have.
Yeah.
If you have an abstract, send me the abstract.
Because, yeah, I have it all.
Okay, good.
But Ursolvant might be a trick.
But he's been on that for ages.
Post repair?
Yeah, absolutely. And it doesn't work.
Pietro, I assure you, 10% of the loops are dysfunctional, and it is written for the Whipple procedure, and it's a mess. And I'm sorry to say to you that there is no good solution. But just remember that he is 80 years old. He has one fever a month. Okay? Well,
but
so that's not very...
But I honestly, the 10% of loops that are dysfunctional are not my experience at all.
That is written in the literature. I agree with you. It's not 10%. It's 3%.
I mean, the failed biliary repairs, for me, this is the first one. Now, I haven't done a 300 like Mr. Bismuth, but normally, when I fire the bullet of biliary repair is...
Can I respond something?
Yes.
When you do a repair and maybe the patient has that and you don't know, because it's it's very important, and Professor Bismuth told us to follow up all our repair, but sometimes we don't, and sometimes you see the patient and you say everything okay, yes, everything okay, and if you just dig, you see that they have sometimes some fever, but not very, just one day, and well, going through that. So I think that it can be dysfunctional.
I think you're right. As often. Not always.
Laurence, I always say that the treatment of the bile structure is a problem of plumbery.
Yeah.
If you are sure it's open, it flows regularly, you don't have problem in your lavabo, it is sure. And the problem are first obstruction.
Yeah.
It could be reflux. You have always also in your lavabo you have problem of reflux, but it is difficult for me to imagine that the bile duct well drained have a permanent obstruction. It's possible, a short obstruction, but with a good flow, it disappears. So it could be what you said. You said 2%, 2%, 2% cholangitis without any obstruction. What you said?
Yeah.
Is the patient he never traveled, of course, just to make sure he wasn't in Asia or whatever.
No. He's been.
Okay.
Professor, can I answer the professor? You said it's primary, okay, but it's living primary, and the intestine is it's not natural to have intestine in next to the bile duct. So I think that it can be dysfunctional. For example, you have sometimes gastroparesia, and you don't know why, but the stomach doesn't work, and it's however, there is no stenosis. It's just a problem of nerve, of motility. So I think that sometimes there is something like that. Of course, sometimes there is a mechanical problem, and I just recently operated a patient with this type of problem, and it was a dysfunction of the loop because it was twisted. So I understood that it was a reflux, and not permanently, but when the loop was twisted. So we have to check everything, but even after checking everything, we have some cases like that.
What is living primary? And you speak about spasm. Do you
Yes.
think that spasm, did you see spasm in the choledochus? I always
No,
said
but in the loop, in the intestine, yes.
inert. Choledochus, there is no...
Yes, the choledochus, but not the intestine.
Intestine. And
yes,
now it's
the loop.
But reflux, I agree there is some, antiperistaltism.
Yeah.
I have patients, I observe patients, they have antiperistaltism in the small bowel, but they have diarrhea. And when they have patients with long episode of diarrhea, long history of diarrhea, be careful about the length of the jejunal loop. And at that time, you may increase the length to be sure. This is why, before I say jejunal loop must be 70 centimeters, I observe case of cholangitis with loop of 40.
Yeah,
Before 70, it was 40, and 40 was not enough. So I put to 70. But in some patients, 70 is not enough. And
maybe.
Then to increase. And we observe by the barium transit, reflux in jejunal loop, even in 70. This is why we say that. But there is always aerobilia.
Yes, always. I agree with that.
I don't.
That's why I was asking.
I remember, if we have time, one of my patients was a radiologist. And when he had pain, he take a radio, and he take the radio standing up. And he came and showed me, look, when I have pain, look, there is air in my bile duct. When it was radiologist, he did several radio in the day. And when there is no pain, he showed me there is no air. That means he showed me the proof that the reflux was there when he was pain. And then this is one of the patients, I increased the length.
I agree. Okay.
We don't talk about the jejunal loop. Sometimes there are also this, I may say, this confection of jejunal loop. I remember I have not only one, but several patients with an inverse jejunal loop. That means it's not jejunal, but ileum. And one patient, they put two mistakes. They did two mistakes. Not only it was the ileum, but they put the upper part of the ileum in the bile duct. That means all the intestine was going in the bile duct.
That's not good.
It was not good, not very good. Not very good.
Okay.
No, we 2 times in my experience, we anastomosed the wrong end. I saw that. And we, instead of simply suturing up, dismount and do it. I've seen that twice.
But your patient has been operated twice. So the technical problem is
No,
very not, it's not probable, I think.
And then when you have the oral loop that is mounted on the bile duct and le pied de lance on there, you have reflux. Absolutely. So this is not this. Surendra is.
Yeah, Pedro. Let me put a wild guess. Okay, I don't know whether it's the right thing or not, but this patient had multiple episodes of cholangitis, multiple endoscopic interventions, and must have been getting a lot of antibiotics every time. So there's a possibility this gut flora is completely changed. Okay, and that is what is creating problem now. So since we talk about the probiotics and all that, now one of the things which is being tried is the fecal transplantation, to change the gut flora to the normal. Would you like to try that? I have
we may. That's one of the things.
I have no.
I've asked our microbiota specialist to think about this and to make a proposal.
Yeah, that's good.
But I have another question to ask you, Pedro. The symptom of the patient who have cholangitis, of course, he has fever, he also tremor. What's his exact?
Yes.
He went to 41?
Yeah. 39, 40.
And what are the biology at that time?
Normal.
Are you sure? You take the blood sample at the time?
Yes. I mean, he has got CRP, which is increased, but his liver function tests are not altered.
No. This is an important point. You know, I know patient that was sent for me for cholangitis. It was not cholangitis. It was only, I remember one have a dental abscess. And he sent to me for cholangitis.
Yeah. So we did a PET-CT in this patient. We turned this patient.
And tremor.
He did everything.
Biology was normal.
Yeah.
I was sure. Another patient has, what do you say, bone osteolytic.
Osteomyelitis.
Yes. So be careful about that.
Yes, but I can be careful, but I can do something more, like a PET-CT, a colonoscopy, a dental status, ENT status. We did everything.
No. Only when you have cholangitis, there is alteration of, unless the gamma GT.
I thought that until this patient.
And the bile culture were negative, right?
Oh no, bile culture is a zoo.
What is the highest bacteria?
The highest?
What did they find? Enterococci, what did they find?
Oh yes, we found on the, let me see, we have a complete Klebsiella, Physium, ESBL, Quacca complex. We have Physium again. Other, I mean, he's followed up by a very good infectious disease specialist who's adapting the antibiotics. But if I I think most of us have shared their experience. I think we can maybe move out to the next case. I will retain liver biopsy in the right liver, may give us something. Really look for one duct that may not be drained and that we could drain. Fecal microbiota, so microbiota manipulation, intestinal decontamination with the magic potion of Laurence.
Cholangioscopy.
I propose
Cholangioscopy.
Cholangioscopy, yeah. But he had through the loop, right?
I propose another test. You inject in the loop a small part of barium and look at what is the transit of this barium in the loop. If we go down, or if we go up.
Down.
Now, the bacteria you gave to us are GI bacteria. They are not specific of the bile duct, GI bacteria.
No, absolutely, absolutely.
It could be diverticulitis to your patient, colonic diverticular.
Yes, yes, but we did everything.
What do you think, Laurent?
Paludisme.
Absolutely.
No, I think,
yes.
you know what? You're screwed up. Whatever you say, do, just do Doliprane maybe for the fever. That's good too.
Yes, this is what I do.
No, fever. There is no localization of the fever. General symptom.
Yes, absolutely.
No pain on the right.
Nothing.
No. No pain in the shoulder. Nothing.
No, just he has severe pain in the right iliac fossa every time.
No obstructive biology of the liver. How do you know it is? How do you know it is cholangitis? It's amazing.
because he
spend
feels
all the day with that.
It is exactly the same thing he's had now for 20 years.
So what else? Let him.
He knows it.
The dentist. Send to the dentist. Send to the dentist.
Yes. I will remove all his teeth. Right. We are recording. We must be serious.
Yeah.
So, but in fact, there are several hints I can go and think about. There is one last thing. Now, cholangitis in the presence of aerobilia and no reflux. I've seen aerobilia is no a guarantee that there is a good bile flow.
No, but it's a guarantee that is not a stenosis.
No, I don't. This is something I don't agree, Laurence.
Huh?
I've seen stenosis and aerobilia, also because aerobilia can be made in the liver. But I've seen many dysfunctioning stents with stenosis and with aerobilia. And you change the stent and everything goes over.
No. It's different. For prosthesis, for stents, I agree. But for anastomosis, I do not.
Right.
There is one little more thing. Think about actinomycosis, because you won't find it in the culture. You will find it in the biopsy, in the liver biopsy, and it has been documented that you can have cholangitis secondary to actinomycosis. Usually, it's a patient who has
cholangitis.
Yeah, it is possible. For example, a patient who has a dental problem, they develop biliary infection, and it's related to actinomycosis, but unfortunately, you can't find it in a bile sample. You will find it only in a liver biopsy, tissue sample. So,
right.
Just,
I may do that.
Yeah.
Beautiful. I will start by the beginning. The first step is to know if the bile duct is the cause of the fever. But what you said is strange. You said he has episode of fever, very severe, repeated, in a patient with a long history of bile duct. I agree for that. But today he has fever, biology normal during the fever, no sign of localization in the right part of the abdomen, upper abdomen. How do you know it is cholangitis?
Yeah.
Only the past history.
Only because it's exactly the same thing he's always had. When he had stones, when he had strictures and all that. But today I can tell this is not my problem, but I'm not sure it will be very well perceived. Also because I really looked for another cause, because I was happy to say this prostatitis, diverticulitis. It's a colonic polyp. It is.
Pietro, I say the first step. I don't say it is the solution. I say the first step is to be sure of that.
I've already taken that step.
After you progress.
That's what I'm saying. Right.
Okay.
But thank you very much. I mean, I think it's been a very interesting discussion. Shall we move on to the second case?
We have a case from Lisbon.
Who has a case?
We from Lisbon.
Lovely, thank you.
Hi. We have a case about also cholangitis. Francisco, our resident, will present to us. So could we start?
Can you hear me now?
Yes.
Okay, good afternoon. As Dr. Silvia already presented, my name is Francisco. I'm a resident from Hospital Correio Cabral, HBP Center, and Professor Hugo team. And so today I bring you a case report from our hospital, which is a male that in November 2020 got diagnosed with a distal biliary duct tumor. And 1 month later, he was submitted to Whipple's pancreatic duodenectomy. He had an uneventful post-operative period, and his pathology report stated a biliary tract adenocarcinoma in EPMND, moderately differentiated, and a PT1 and 0R0. His follow-up initially was asymptomatic and without evidence of oncological disease. And in December 2022, so 2 years post-op, he was submitted to a follow-up CT scan that I will now show you. So, as you can see, it's normal CT scan. And in a follow-up CT scan the next year, in October 2023, that I now show you, we can see that there is a intrahepatic biliary dilation without signs of oncological recurrence. And this biliary dilation is especially on the left and posterior sector. And so it was decided to reevaluate the patient with an MRI. But between the two exams, the patient had 2 episodes of acute cholangitis. And so in the March, the next year, March 2024, in the MRI, that I now show you, we can see that there is a 35 millimeter nodular hypodensity in segment 4, and this bile duct dilation. So I would now like to ask for your opinion on this dilation and hypodensity in this first moment for discussion.
Right. Can you stop the screen sharing so that we can see all the participants?
Mm-hmm.
Right. Yeah, who would like to speak first?
It seems to be an abscess, an intrahepatic abscess after an enterocolitis. And let me just check. It was an IPNB on the first pathology. So it could be a recurrence on the biliary tract.
Yeah.
Because it's a disease of the biliary tract. So it can be a recurrence inside the liver. Maybe I didn't see if there is a stenosis or multiple stenosis in the healer, but maybe it's that. Or it's again a problem of reflux.
So he should start the workup to discriminate whether his bile ducts are emptying okay, and whether he's got anything structural that makes poor emptying of the bile ducts. Could be a stricture, could be a papilloma for the IPNMB.
There's no document of stenosis at this time.
Can you hear Dr. Sylvia when she speaks?
Very little.
Any symptoms? Did he have any symptoms?
No symptoms at this time.
So it's an image.
Yes.
So in our multidisciplinary meeting, it was the conclusion that it was a suspected post-cholangitis hepatic abscess, and so the decision was to repeat the CT scan and blood tests. So in July 2024, this is the CT scan, arterial. Okay. Portal phase. And now the portal phase of the CT scan.
There is a rubilia.
No, there is no.
Yes.
Here we can see that there was a decrease in the abscess size and a maintenance of the bile duct dilation, especially the maintenance on the posterior sector, but a worsening of the left duct dilation. And so
I presume that in the meantime, he had antibiotics.
yes, of course, yes, treated cholangitis. So again, discussed in our multidisciplinary meeting, abscess in resolution, and the decision was to perform analytical and imagiological vigilance on the patient. But again, September 2024, an intercurrence with acute cholangitis. And so this is the inpatient admission CT scan. Okay. So there is still this progressive worsening of the left dilation. And now we can also see that there is the small filling defect on the left intrahepatic portal vein that was not described previously. Okay. So this time it was a 5-day inpatient stay with IV antibiotics, and due to the suspected portal thrombosis, and the patient started anticoagulation. And so he had an indication to perform the MRI that was in an outpatient regime. So this is the subsequent MRI that the patient did. Okay, this is the biliary reconstruction. I can show. And this is all right. This is the other phase of the MRI, and so last we can see that there is still this intrahepatic bile duct dilation, but this time in segment 2 there is a defect in contrast filling with adjacent inflammatory changes, and there is a suspicion of the presence of a fishbone. And also, there is a progression on the left portal vein thrombosis that in our multidisciplinary meeting, it was discussed, and it was of non-tumoral etiology. And so, and it's also discussed that there was no stenosis of the hepatico-jejunostrum. And so, right now, we have this patient with decreasing the value of their blood test for alkaline phosphatase and GGT are decreasing, and there was a slight increase in his total bilirubin value from 0.6 to 1.16. And this is the, I would like to ask you what's your opinion on what to do with this patient.
Did you do CA 99?
Yes, it's normal.
Normal, yes.
We don't have any evidence of recurrence, but we have now a fishbone in the left bile duct. And actually, when we start to look at the retrospectively to the CT scan in 23, we have at that time fishbone in segment 2, as you can see here, and now on the left branch.
Yes,
Need an operation. Your patient needs to be reoperated.
We don't have stenosis of the bile duct. Do you operating now to take off the fishbone and redo the hepatico-duodenostomy?
Yes.
You can puncture the loop and go up endoscopically.
It's the only solution. It's it's not normal to have a fishbone in the bile duct. It will have endocarditis, and this is quite serious. You have a thrombophlebitis of the portal vein. You have a left lobe infected. So I think that you have to operate this patient.
Yeah.
Left lateral.
Operate or endoscopically.
Operate.
Yeah. Operate, and I'm sure you will do a left lateral segmentectomy.
Left lateral. Now the fishing bone is already at it's near the hepatico-duodenostomy, so we will see with US with the ultrasound intraoperatively if we can preserve or to perform the left lateral.
Who's been putting a fishbone up there?
I don't know. Anyone here has seen this before?
No.
We have already some cases of fish bones in the liver, but not in the bile duct. But actually, we have a hepatico-duodenostomy, so maybe from the hepatico-duodenostomy to the migrate to the left duct.
But I agree with Laurence. What worries me is the phlebitis. So you have to operate because that's very dangerous for the patient.
That's what we think also. We start the anticoagulation, but it doesn't better now. And we are thinking the same, and we will form the redo surgery to redo the hepatico-duodenostomy or left lateral. Thank you.
Thank you.
Thank you.
Any further comments on this case?
Your micro.
You are muted.
During the operation is just to explore the right duct and probably do the KRAS test and the liver biopsy on the right lobe. That's what I will do.
Okay.
Surendra is want to say something?
Yeah. So what are we seeing here? It is a fishbone causing inflammation of the bile duct, causing stenosis and phlebitis in the adjacent left branch of the portal vein. Is that the thought process here?
That is the hypothesis, as I understand.
So if that is so, should it not be that removal of that fishbone, whether you do the PTBD, put a tube there, you can put the cholangioscope, remove it and see how the bile duct is, and then take the biopsy and brushing from there, by chance it is a malignancy.
Yes, I think that cholangioscopy is a good option for this patient.
Yeah.
For this once, I disagree with Laurence. I said that you can do it endoscopically.
We don't think that our gastroenterologists in our multidisciplinary meeting, they think that they can't reach the fishbone by endoscopy.
Other thing is the endosono US evaluation. That can be done through the stomach, and good therapeutic endoscopists, they can approach the duct through the stomach also. But I think a PTBD will be a simpler way to do. Then you will know whether there is stenosis or not, because you can inject the contrast and see whether it's flowing across the left duct or not.
I mean, if you see, I've showed you the film of the cholangioscopy of our patient who had multiple papillomas of the segment 3 bile duct. And I think that can be done in a similar way.
Yeah, but I think that because of the Reunião reconstruction, and they don't have the enough left of the endoscope to reach the.
No, you can do it. You can do it percutaneously. You can puncture, yeah, you can puncture the loop, and
by the liver.
Yeah.
But we don't have from the left side, because we don't have a dilatation of the whole bile duct, but we have from the left side. You can go by that way and try to reach the bone and take off the fish bone.
Well, I can show the X-rays to, or you can discuss it with our endoscopist how we would do it.
Okay. Thanks.
Right.
How you define your case? Is a case of?
Sorry?
How you define your case? Is a case of, if you want to present, is a case of left lobe, left
Fishbone.
Left lobe cholangitis from foreign body, open bracket, fishbone, close bracket, in the left bile duct.
In the patient with an IPMN.
Yes.
That's the problem.
There is relation between the two?
So far, we don't know, because cholangioscopy has not been made. But I think that cholangioscopy would be the good option for this patient. You would see everything. You would see how much IPMB he has, if any, how well is the left bile duct and possibly the other bile ducts. And Hugo has joined the meeting. Yes, I think cholangioscopy is a good point.
Okay, we will try and then we will tell you.
And our gastroenterologist, but I'm sure some others are available to discuss it if with your equivalent.
It's a Whipple procedure. It's
Yeah.
not so easy for the loop.
Yeah, but it can be punctured.
Yes.
Percutaneously, you can do it.
Oh, yes, but it's
Easier said than done.
It's
But
not so easy after Whipple.
no. Now, any other cases?
It's about metastasis, liver metastasis.
Yes, we are all here, Laurence.
You want? Oh, in fact, it's not a strange case. It's I try to share my presentation. So it's quite easy. It's about strategy. This is a female, 40-year-old, and she's a nice nurse with no history, no medical history, no surgical history. And she experienced an abdominal pain in October. Unfortunately, the CT scan revealed a cancer of the right colon with 4 synchronous metastases. And she has anemia, and she has, as you see, a tumor marker a little high. It was, I'm sorry, it was 9.9 for ACE, and for CA99, it was 600. And this is the mass in the right colon. It's an ileocecal mass, which was palpable with lymph nodes, regional lymph nodes, and 4 liver metastases, as you see here in the MRI. It's the one in the upper part of the liver in segment 8. 2 other here deep in segment 8, and a little one just close the right hepatic vein 1 centimeters. You see the round is not well put. It's here. You see that?
Yeah.
Okay. So this is the PET scan. As you see, it confirmed a very large mass, the primitive mass here with the lymph node, regional lymph node on the right. And as you see on the PET scan, it confirmed the 4 liver metastases. And they spoke also that there is spots in the left lobe, just one very small spot, very difficult to see on the image, and another described in segment 6. Nothing elsewhere, no pulmonary metastasis, no carcinomatosis. So what is in this patient, young patient with right colon cancer, and 4 metastases in the right liver, with some doubt on the PET scan, which is not easy to see on MRI or on CT scan.
Laurence, can we see the images again, the first ones?
Of course. So this is here on the CT scan, the mass, okay, with the lymph node, as you see here, okay? And this is the first one, 1 centimeters, 0.1, 2 larger one on segment 8, and a small one exactly near the vena cava and the right hepatic vein. So 4 metastases, small one.
Laurence, did the patient already undergo chemo?
No. This
So
is the initial
MSI
presentation.
stable, MSI stable or unstable?
MSS, KRAS mutated.
Okay. I have a question, Laurence. When you have a patient like this, you discover it's just the beginning of the story. That means that you discover the colon cancer at the same time from liver metastasis, and 2 are very small.
Yeah.
We may see 4 liver metastases, but can you imagine it could be some 2 millimeter?
Of course.
So what is the limit? What is the limit of all the investigation that we have to see the nodule less than 5 millimeter?
I do agree with you.
It's not for you. always blocked for this kind when the first time we see the patient, he has 4 small metastases and 2 very small, 2 at the limit of the visibility. Can you imagine that the nature stop only to let the metastases to be seen by the surgeon?
You made a good point. That's the problem of all the management of metastases. So that's why I think it's interesting.
Many the synchronous, many the synchronous liver metastases.
Yes, synchronous. That's what I said. It's the problem of synchronous metastasis, and this is what I want you. I want you to know. I want to know how you manage this patient.
So for this point of visibility of metastasis, of very small metastasis, we usually do for multinodular metastasis. We always do primo-vist MRI. So where the specificity, the sensibility of the exam is higher than gadolinium usual MRI.
Absolutely, but
So,
I think this is not primo-vist.
Okay. We have not primo-vist, but multi-Hans, which is the same, and it is exactly the same.
Yeah.
You have exactly here the MRI, CT, and PET scan with the best exam we can have.
Yeah, Laurence.
Yeah.
I raise the hand. You moderate your own case.
Okay.
Can I just?
This is not finished. Okay. Unfortunately, I didn't see this patient at this time, and I don't know if what you do. Who will do a first chemotherapy?
I will.
Everybody?
I will too. I will
Okay.
too.
Knowing that.
I will do first primo-vist, then chemotherapy.
Okay.
Yeah.
Primo-vist. Okay.
Yeah,
Do
yeah.
primo-vist, do PET scan, do whatever you want.
Well,
So chemotherapy. Okay.
Yeah.
That's what we did. 4 cycle of FOLFOX.
Perfect. Yeah.
And I see her after this chemotherapy. She was very well, no pain. The mass was still palpable on the lowest part of the abdomen. And you see that it worked. The tumor markers were lower. And we perform a new CT scan and MRI. Don't ask me, we didn't do primo-vist, okay? So this is, unfortunately, the MRI. So we have 2 missing metastases, the upper one, the one near the vena cava, and as you see, the 2 bigger one, well, we just see the shadow of these metastases. So it worked very well. Okay, but when we perform and we believe on that, maybe more than primo-vist, the diffusion sequences. And as you see on the diffusion sequences, we see on the blue arrows, the metastasis, the one on the upper side in segment 8, subcapsular on the left, the 2 major one, but we didn't see the smaller one near the vena cava. Disappeared. And we saw 2 new spots that didn't existed before, one in segment 4 and one very doubtful on the left side. Okay, this is the situation now.
I comment. That means that chemotherapy, you draw back the, let I say, 1 billion tumoral cell to 100 million.
Yeah, agreed.
You know.
So what do you do?
The problem, you know, when we think about nodule and so on, it's correct. But if we look at the tumoral cell, there are billion at the beginning. You may calculate, you know, the human body has 30,000 billion of cells. The liver is about 1/50 of the body. That means it is calculate 150 on 30,000 billion cells. Can you imagine how many million cells? That means by chemotherapy, of course, you gain, but it's terrible when you have at the beginning of the disease already 6 liver metastases. We may think that they are small outside. So
I'm sorry, Professor Bismuth, it's the death of surgery of metastasis, what you say. It's really depressing.
No.
Yes, because we are doing surgery for much more than 4 metastases. So it's the point. At each time we are dealing with metastasis, multiple metastases, it's always the same. The problem here, I want to focus on missing metastasis and strategy on this synchronous in a very young person. Yeah. She is 40. We have no right to make that decision. So what do you think?
But I agree.
Let's hear Valerio then.
So my attitude would be to do a synchronous right colectomy and resection of all the metastases. The question is there a place? So I would do a segmentectomy 8 and resection of scars of the if we see them of segment 7 metastasis, if we see them, of course. The question is, could we use instead of resection? Could we do a thermoablation, microwave or radiofrequency? I would do resection personally, but the place of thermoablation would be discutable. Yeah. So I would go to straight surgery of both colon and open technique, not in laparoscopy.
Right.
You go.
Yes, I would do a similar thing, but we have to think that when a metastasis disappears, it is very difficult to resect the place where we think the metastasis is, and be sure that in fact it was the same area. This happens a lot. Sometimes it disappears. We go there, we try to resect that segment, and in fact we see nothing, and we are not sure that the metastasis is not there. So if it's not synchronous in these situations, I would wait probably to see if they can appear again to try to resect them. In this situation, I would do the same as Valerio. I would go resect the primary and resect the metastasis that I have seen in intraoperative ultrasounds. I wouldn't try to resect the other sites.
Okay. Gina?
Oui. Laurence, me, I always, even if they are, it's a partial response to chemotherapy, I would say, because it was positive to chemotherapy because you have the tumor markers who come down, and it was a protocol of FOLFOX that you gave. So I will do definitely a synchronous resection, of course, right hemi and right hepatectomy, extended to the segment 1 because the tumor was really near the hepatic vein, as you showed us, the first image. So I will resect all that, and then I will do an adjuvant chemotherapy with a different protocol of chemotherapy to look for the left lobe, because she's young, as you said, so you have to give the maximum of therapy. And I don't know if you said it before, there was nothing, I assume, in the lung. There was no...
So you choose to do a right hepatectomy for that?
Yes, I will resect all the right lobe because you have micrometastases non-seen.
In fact, I ruled that was the decision on the staff, but I ruled off this situation because I think that it's a pity to resect all the right lobe if there is any recurrence in the left lobe. So I didn't do that.
Hopefully Roberto is not here.
I would.
Yes, of course. I think that Torzilli would be absolutely down.
Yeah, but there are lesions in the segment 1 near the hepatic vein, and I'm sure you have micrometastases that will recur. So
I agree. That's the concern.
I agree with that.
Can I say something? I think we have to discuss two questions. One is which time we do surgery. That means we may prolong the chemotherapy or not, or do surgery now. And two, which type of surgery.
Exactly.
For me, I have my two answers, but of course, other may answer differently. My two answers is perhaps to do 2 more cycles of chemotherapy and then to do surgery, but very economical. For we don't know where will be the next. And three thing is to do surgery thinking at the repeat operation. I am sure there will be mastectomy.
Yeah.
That means
That was
to be economical in the dissection, not to dissect largely the celiac trunk and so on. Economical surgery, economical resection, and we may discuss the time now or a little later.
I completely agree with that. But I didn't choose to do 2 more cycle because I don't know what to. Well, it will be most difficult to see the scars if there is. So I decided as you to operate. In my mind, it was to resect the primitive tumor and to explore the liver. And that is what I found.
Yes, this is
Yeah,
this.
Laurence, I mean, if you treat in order to let the tumor disappear, it's very difficult after. It's confusing.
Of course.
I
So
agree.
I'll explore the liver. It was totally impossible to find the scar on the segment 7, you know, near the vena cava and the hepatic vein. It was impossible, and I knew where it was. It has no. It is impossible on the palpation and on the ultrasound. And so I found the subcapsular in the segment 8. I found, of course, the 2 majors one, and I didn't find any scar on the little spots on the MRI, even if I knew exactly where it was. So of course, I didn't want to do a right hepatectomy for those small lesions. So I performed exactly what you said. I did a segmentate and another atypical excision and performed the right colectomy. And in fact, my objective is to do after an intra-arterial chemotherapy postoperatively, because I think that it's the best to make really disappear and cure the very small metastasis in the liver. But I think I wanted to present that because we have this discussion on our meeting, and it was very, very different in the opinions. Some wanted to do a right hepatectomy, some wanted to do chemotherapy until it all disappear and make a stop. And I think that in this case, the right colectomy was necessary because it was a big tumor.
Yeah.
So I don't know if it will work, but I think, as Professor Bismuth said, that this young woman, unfortunately, will recur in the liver. And that's why I think that it has to be an economical resection.
Laurence, can I say something?
Yes, you can, of course.
Yeah. I perfectly agree with you, but I'm not too sorry to abandon what I can't see. Now, I've done it several times, and some of them do not
reappear.
Up again, or reappear, about a quarter of them. But it's always that to take. And if they reappear, that you go back.
Yeah,
and you warn the patient that you go back. And we say in Italian, se son rose fioriranno. If it's the aim of the chemotherapy is to eliminate the microscopic disease and to circumscribe, and it does it, to transform from replacing into a pushing pattern the metastases that are there. So it's no big deal to go and redo an hepatectomy when you see the metastases. What I've abandoned to do is to do blind resection based on anatomical landmarks, because that is a recipe for our one parenchymal resections, which are poor.
I agree.
And
I agree with that.
it's
I
the
agree
third
with that.
thing. I think a
That's
right
not what we said.
hepatectomy here is a state-of-the-art fault. It has been demonstrated that if you
No.
treat these patients with major hepatectomy, they die earlier.
Mm-mm.
And that just
This is not what we said. No. This is not what we
we
said.
can argue, but there is a literature on that
I agree.
patients who had extensive resections
Mm.
or small metastasis die earlier.
It's not the question of doing extended resection for micrometastasis. I just want to make one remark and then I leave it open to discussion. What I learned is that you have micrometastasis. We've seen lesions that some of them disappeared during chemotherapy and some other have reappeared. What I've learned is that you resect based on the primary images. Even if they responded, you take off this lesion.
No longer.
Based on one principle is that if the patient stop the chemotherapy, the lesion will reappear because you need one cell that reappear the lesion. So that's why you have to resect what you've seen before. This is what I've learned. So maybe I'm wrong,
yes,
but this is what I've learned.
It was what it was said before, but I think it changed with the efficiency of the new chemotherapy, and it is so difficult to resect the scar. The problem is the balance between resecting all the scar, which would have been good for all the metastases present, but if it recur in the left lobe because we have a doubt, it's a pity. It will be very difficult to cure. So I did exactly what Valerio said. I was laparotomy, and my concern was should I dissect all the liver, because it's to find this metastasis on the vena cava. I had to dissect the liver. It would be difficult if I go back for a new resection. So I think that when we can't see the metastasis on the MRI, I think we can't see it in the patient. What do you think of that? Because
Laurent, may I ask you?
Except if it's subcapsular, but if
Yeah.
it's deep in the liver,
You
if
won't
you
see it.
can't see
Yeah.
in the
Laurent.
I agree.
MRI, you can't see on MRI.
I agree. I agree. You won't see it.
Yeah. Laurent.
May I say something,
Yes,
Laurent?
Felice, sì.
Yes, I agree completely with your strategy, and I would do the same. But may I ask you if you currently use the sonoview during intraoperative ultrasound? Because, of course, if you have subcapsular lesions, you can find it, the scar, okay. But the sonoview is very, very, useful in these tiny lesions. Also, when you have some anatomical landmarks, and in this case, you add the vena cava, and I think also a branch of the right hepatic vein, if I have seen well. But I would like just to know if you use yet or sometime the sonoview during the exploration, the intraoperative exploration of the liver.
Always.
Not me. In fact, when I have some difficulties myself to find a metastasis, I am calling a radiologist in the operating room to confront and sometime he does that, a sonoview, but for very, very small. And when I say small, it's less than 3 millimeters. It can't see. They said it's no use to do that. If it's 5 millimeters, it can see, but you can see also on CT. And the problem is when the patient had a lot of chemotherapy and has a blue liver, so it's impossible. That's why I when there is very small metastasis and sometimes missing, I stop the chemotherapy early
Yes.
not to have those terrible liver where ultrasonography is unuseful.
May I add, I've used Sonoview and I stopped using it because you just see the impregnation during a brief period of time and then it washes away. So it's difficult to work, and I think it doesn't stay for a long time.
Yeah,
So
it's
Do
very
you know-
difficult.
do you know, I-
You have to
you know
focus on the lesion. You have to find the lesion and do the Sonoview. It's very difficult. I gave up.
What is your
do-
protocol?
If you know the SAT region, if you know the SAT location, you can use with the Sonoview in the region where you can't see a plain ultrasound, and you can use the Sonoview and find it. Also in very tiny, because of course the use of Sonoview by the radiologist with external ultrasound is very different from our technique during the operation with the intraoperative probe. So yes, of course, you have to know where find where looking for the lesion. In this case, you had some precise
Yeah, you're
anatomical
right.
vascular landmarks. So in my experience, very often the use of Sonoview is useful. I have to say that.
Okay.
Can I say just one thing? I think so. I totally agree with Pietro's statements, and really there is no big deal to do a rehepatectomy in those cases. And I just want to point out your last statement, Laurence, on planification of intraarterial chemotherapy, which we believe a lot. I think in those patients with very small multiple metastases in the liver, there's for sure, of course, there are other spots of metastasis that we don't see, and there is really a place for intraarterial chemo, adjuvant intraarterial chemo. We did a study in our center, a retrospective study, and we saw that those patients who had multimetastatic intraarterial metastasis, the survival was better in patients who had intraarterial chemo. So I think this point is important.
I think the complete response rate in those patients is also very high, I think.
Is higher, yes, exactly.
There is a
Laurence,
we
may I
know.
suggest something to you? You know, I was thinking many time ago about the possibility to inject in the very small metastases that you don't remove by a fine needle punction, a very small amount, less than 1 drop of liquid with metal, with iron, the power of iron, in order to find them when they decrease. For they will disappear with the chemotherapy. So, of course, I did not practically find a solution, but see with radiologists if it is possible to do that. What do you think?
Of course, it has been done, of course, but for these metastases, just in the corner of the vena cava and hepatic vein, it would have been difficult percutaneously. But I think that it's a good point.
At time of operation.
But I didn't see it. I didn't see it. In fact,
no,
it was
the
impossible.
one, the very small one that you find that you cannot remove. That means I say that for all metastases, if you remove all of them, of course it's okay. But if you let some very small, if you see them,
I didn't let small. I didn't see any other. In fact, it's that's the point. That's the real missing metastasis. But we have that. It's for me a very difficult topic. Those missing metastases. But of course, as Valerio said, I think the best is to propose intra-arterial for the small metastases. And the point is we have to make chemotherapy and particularly oxaliplatin very few cycles before in order to have a possibility of doing after this intra-arterial before damages of the liver. So I don't know, but Well,
What
it's
type of chemo, intra-arterial chemo do you use in your center?
oxaliplatin.
Oxaliplatin, okay.
Yes, oxaliplatin.
Yes.
Do you give aspirin for your oxaliplatin patients?
What?
No.
Do you give aspirin to
No.
your oxaliplatin patients?
No.
No.
Because there is evidence.
Except if there are headache.
Yeah, there is evidence that it decreases the SOS.
Really?
Really?
I didn't say. I didn't know.
Avastin
I
does.
didn't know that.
Avastin does, and aspirin does.
Okay, good point.
Now I haven't followed the literature, but that was one when Laura was following very carefully all that, and it was a point. I mean, it doesn't cost anything to give aspirin.
Yes, of course. But the point, I don't know what your experience, but it's very funny, this toxicity of oxaliplatin. Sometimes you operate somebody with 4 cycles and you have a very blue liver, and sometimes you have 10 or 12 and the liver is perfect. So, well, I don't know if it's
we
difficult.
respond to chemotherapy in a different ways. Now,
there's one question
10 more minutes for the meeting. I think this was a very interesting discussion.
There's just one question on in the chat. Is if we use fiducial to mark tumors that risk to disappear? We personally don't.
It's HOP.
That was exactly what said Professor Bismuth.
Yes.
It was to mark, and I did that with some easy removable metastasis. And sometimes another point is to do ablation, percutaneous ablation before chemotherapy in very small metastases in order to treat them before they disappear. This is another way.
But I've become more happy with the idea of leaving them back, and if they reappear, then take them out. But this could be an interesting point to discuss in at the meeting, Laurence, because we'll have many colorectal experts coming. Nicolas Vauté will be coming, and Hop Tran Kao will be there, I hope. So that would be a very interesting point, because it's fast evolving field. Now, Angelica wanted to say something about the website. We have 6 minutes to go.
Yes, I will pause the record now, okay?
Yeah.